I'll be talking about shock severity scores. These are my financial disclosures. Two other disclosures is I am having a little bit of an asthma attack after flu a couple of weeks ago, so this is not COVID-19, my cough. Seeing a lot of side-eye from a lot of people, so just wanted to preface with that. And third, I'm going to add a third disclosure, which is I'm going to be talking about severity scores, which I find to be less useful than the SKY classification, going after David Barron, talking about more, in my opinion, more inferior scores. So let's just set the stage there, and we can move forward. So I'm going to be talking about two groups of scores. The first, and there's two categories really of scores in this space. One is trying to predict who's going to develop cardiogenic shock after an MI. And then the second group of scores is once you have cardiogenic shock, who of those people are going to die? So I'm going to talk about two scores in the first category. Who is going to develop cardiogenic shock after an MI? And my title had a couple of other scores in there, but some of those were older, and so I wanted to focus on something that's more in the modern era. And this was the ORBI risk score. This was published a couple years ago in the European Heart Journal. Very large cohort for both derivation and validation. Almost 9,000 patients out of Europe and France. These were all STEMI patients, all obviously without cardiogenic shock on admission, treated with PCI. I didn't give, it's a 7-minute talk, so I couldn't go through all the demographics, but just to give you a sense, this was a typical MI population. Only a quarter were female, median age was in the 60s. And what the authors did was they created a score, including some modifiable and non-modifiable variables. I don't know how well you guys can see this from a distance. I can't see it from here. But things like age, Killip class, which we're still talking about, delayed intervention, and then some end organ markers of end organ perfusion. What they did was they were able to create this score that you can see very nicely on the beautiful figure, that as you go on the x-axis from the green zone to the red zone, which, as your score goes up, your mortality, which is on the y-axis, also goes up. They then classified these patients into low to medium to high, and high-risk categories, and saw a stepwise increase in mortality as you went from one category to the next. And because, as we mentioned before, some of these risk scores are hard to apply, I think David actually mentioned we shouldn't, you want a score that you don't want to have a calculator for. This score has a calculator that you can use online, the orbiriskscore.com. Because it's not, you can't just kind of go through your mind, and the EMS isn't going to be able to do this in 10 seconds. The other one I want to talk about is a little bit more accessible, a little bit easier. This was, and this is the shock index. This was derived and validated in a little under 1,000 patients in China. This, again, similar kind of demographics in terms of female-male distribution, age, and they looked at shock index, which is heart rate over systolic blood pressure, and showed a pretty good AUC, right? A C statistic of 0.81. And obviously this needs to be validated in other populations, et cetera, but I think this is an interesting measure for the same exact reason that David was talking about the SKY classifications being good for once you actually have shock, is that it's easy and it has face validity, right? So we know patients in general with a higher heart rate and a lower blood pressure are sicker. And so it's kind of a little bit easier to use and has good face validity, but very much in its infancy in terms of being studied. So now those are the two scores in the first bucket. The second bucket is once we have cardiogenic shock, who's going to die from it? And I'm going to talk about a couple of the scores. I know some of the folks have already mentioned this, but I'm just going to talk about them briefly. So I was asked to talk about the shock score as well, which is in the pre-PCI era. In the pre-PCI era, there were two scores. The reason I want to highlight this is to see how far we've come. I really think this actually shows a beautiful trajectory from this to the SKY classifications right now. So from Gusto and shock, we had two different scores that were derived. A couple things to highlight. These were done in the 1990s, right? This was not the routine PCI era. So applicability of these scores to management of today's patients in the U.S., I should say, is not necessarily something I would endorse. But the thing I really wanted to highlight is what these scores were. So one went up to 102, the other one went up to 260. Right? So in terms of how to use these scores at the bedside, these might be decent, at the time research tools, but in terms of applicability at the bedside, I think this actually sets the stage of how things have evolved. How about in the modern era? So this is the Card Shock Network. Dr. Alessandra had already mentioned this. This was a European prospective registry, collected 2010 to 2012. included ACS and non-ACS. About 80% of patients were acute MI shock. Demographics still the same, 60s, mainly men. Interestingly, a couple of interesting findings. So mortality was about 37% in the overall cohort, but very interestingly, acute MI shock actually did worse, right? They had a worse mortality, and we've seen this signal in a couple of different papers. And as a heart failure doc, I look at this, and we don't, except for David and a couple others, we don't do cool procedures. We don't have we're not super flashy, but what we pride ourselves on is that we take care of the sickest patients. And then this is giving us a little bit of food for thought as well. So they also created this score, and you saw this recently going from 0 to 9. So we went from 260 variables, a score of 260 to 9. And this figure you guys have seen that as we go from 0 to 9, you have increasing mortality. We've already mentioned that there's very little, low population numbers in the low scores, and you see the distribution. And what they saw was that so you can see that on the top figure on the top right. On the bottom is their AUC curve. And what you can see is in the card shock network, in their own network, they had pretty decent performance. They looked at this performance in the IBP shock 2 group, and the performance still outperformed pre-PCI era risk scores, but was inferior to their own population, which from a statistical perspective is something we often see and expect. How about the IBP shock 2 trial? So the shock score, you guys saw this as well. Derived in the RCT population, validated in registry populations. Again, very small numbers for the registry population. Similar demographics, score goes up to 9. Higher score, you're more likely to die. So these were only recently, this was published I think in the last month, they did, a group out of Europe in Spain did try to validate these scores in a small non-selected group of cardiogenic shock patients. This is all retrospective. And what they saw was the AUC curves that we're seeing is about 0.7. So I don't know what I'm going to do with that at the bedside, but it's about 0.7. But not interestingly, but yet not surprisingly, is when they then stratified the group by ACS versus non-ACS, these scores perform much better in the ACS group. Again, not shocking, pun not intended, because this is where all the data came from, right? Even in the card shock network, 19% of patients were in the non-acute MI group. And then I want to mention the INOVA study, which has again also been mentioned and gotten some press. This definitely needs to be validated, but it's the first one that actually includes more heart failure patients than acute MI patients. It includes a couple of interesting parts in their score. We have a CPO, we have PAPI, we have some of the things that we're talking about in the modern era. But it's not also easy to calculate, and it's not that easy you don't have all of that stuff necessarily at the bedside easily at your fingertips. But a very interesting, a great paper, and I think we'll see more to come on this. And so kind of when I put it together, all these scores do, they slice this up in different ways. But on the left, you see non-modifiable risk factors that go into these scores: age, etiology, pre-existing comorbidities. And then on the right, you see some things we can do stuff about, right? So shock severity or duration. We obviously can't say how big of an MI someone's going to have, but we can control how long we do until we support them, what time we have until we support them. Markers of end organ hypoperfusion, again, dealing with how long do we let them sit in shock, and then the degree of cardiac dysfunction, reperfusion, et cetera. And then at the bottom table, I just put the AUCs from some of the different scores, showing again that particularly in the validated populations, we're looking at 0.7. Oh, wait, I don't know how to go back. Oh. All right, I forgot it spreads it out. So in conclusion, I was going to say we have multiple risk scores. Multiple of them have limitations. They've been derived in different types of cohorts. Most of them don't include chronic heart failure patients, don't include a high number of them. Some, the validation of them seems to show lower performance. And my last point was actually I think simpler is better. These are high-risk patients in short, we have to make decisions quickly. And when, I talk a little bit about shock teams and I do talks, I put up all the different components of people taking care of the shock teams, right? And you have EMS, you have ER, you have, you have the hospitalist floor, you have the ICUs, and you have all of these different teams. And the more complex we get, then the harder these scores are going to be to access for people who don't talk in the shock world. And we who do talk in the shock world, as we can tell, still don't agree on what we're talking about. So now we're asking people that don't live and breathe this to try to talk to us, and we have trouble sometimes talking to each other. So thank you.
Very simple question. I was looking at your ROC curves, ACS versus non-ACS. Generally, do you think that they have the same prognosis? And if we use the SCAI definition, class D, acute MI versus myocarditis, whatever else, do they have the same prognosis?
So far we have some data, it's not completely consistent, that the acute MI shock, and I can probably extrapolate it to potentially, but I can't prove this, acute heart failure shock, will have a different prognosis. It's just a different population, right? My patients might have had an SVO2 of 40 for the last 6 months, right? And then now they're coming in and they've they finally kind of slid down this low slope of a hill, versus someone who is completely healthy on Tuesday and on Wednesday has an acute MI or has fulminant myocarditis. So I think the myocarditis we might see shift into the acute MI category is going to have a different degree of end organ hypoperfusion that I think we're going to see. Now, of course, the fulminant myocarditis patient, the stuff that makes this really hard to study is, well, let's say I lump those two together, and we have that 19-year-old kid who comes in with fulminant myocarditis, and the 72-year-old, nothing wrong with being 72 versus 19, but who 40 years of diabetes, hypertension, who comes in, I can't expect those to have the same prognosis from a pure comorbidity and organ reserve perspective. So I think these are actually adding to the complexity. I do think you will see different prognoses until you get to something like stage E. Once you're in stage E and you've coded, I think at that point, I don't know, maybe it'll just sort out to be if you're 19, you might be okay, right? And then that might be the only thing at that point.
One of the things I was struck by was, I think a contribution in the SCAI definition was that contribution of cardiac arrest regardless of stage. And I think, the fact that none of these have cardiac arrest in them really suggests that disconnect. And I think when you're looking and talking about supportive devices for the heart, and you know that the mechanism of death in cardiac arrest is neurological, then when you have 50% of patients in IABP2 and 50% of people in culprit with arrest, it really makes you think about if you're going to have to design trials in which you want the support device to be the modifier of outcome, are we being fair using a data set in which the predominant exit strategy is neurological? And I think it is that disconnect, but doesn't come out in these data sets. But I think what you've done with that arrest modifier is really put attention to future trial design using that index event.
And a lot of those trials were derived from, the trials included patients who had cardiac arrest, and some of the trials included that as a variable. But again, I almost view this, the other conclusion point I had is a lot of these are common sense variables. And so it includes it as a variable, but I agree. I think from a trial design, people who arrest versus don't is two completely different populations.
You're bringing a great point about acuity playing into this classification. Because, for example, when they came up with the Intermax profiles, they solved the problem of classifying patients who were all in class 4, NYHA class 4 heart failure. So the approach to shock patient may have some similar feature, because as you said, if somebody walks around with mean blood pressure of 60 all the time, 75 or even 65 should not be the target for this person, therapy-wise. Classification-wise, they shouldn't be put in the same basket, in the same class as people who develop the same level of hypertension acutely, because they're going to respond differently. Same with mixed venous saturation. If somebody is at 55 for the last 3 months, their level of hyperperfusion is going to be quite different from somebody who dropped acutely from yesterday.
I mean, as an advanced heart failure doc, outside of the shock world, I spend a lot of my time just repeating that my patients are not like other patients, right? Like
Directly to your point, there was recently, Esther, there was a paper last year from Hopkins that looked at shock, ischemic versus non-ischemic, or acute MI versus not, and in that study, looking at cardiac power index, non-ischemics, the chronic patients, non-dilated cardiomyopathies, they had a 2 to 3-fold survival for a given, increased survival for a given cardiac power output. Having said that, in the cardiogenic shock working group, where we have, almost 3,000 patients from 15 hospitals, the SCI definition, survival was the same for a given SCI definition in ischemics and non-ischemics. So they're measuring different things. The hemodynamics and the SCI definitions are measuring different things and prognosticating different things.
And that's actually why I like the SCI definitions too, is that then it kind of evens the playing ground, levels the playing field.
While we're waiting for the microphone, just a bit on cardiac arrest. In the CVAD registry, which is the National Impella Registry, there were 51 patients in cardiogenic shock with anoxic brain injury that were treated, and 46 died. So it's like more than a 90% mortality. And I just really want to remind people that although they are in cardiac arrest, it really is a neurologic outcome that's going to drive the process. And so for the NCSI, we've excluded people that have cardiac arrest with anoxic brain injury. If you have a VF arrest in the ER and in the setting of an acute MI and you get promptly defibrillated and the patient's wide awake, I don't think that is a cardiac arrest, but I don't think that that's really what we're looking for. We're looking for a cardiac arrest with prolonged downtime. That's really the thing that drives the prognosis.
And when you look at, we've talked about the IMPRESS trial a bunch today, but this weekend, the median cardiac arrest time was not 10 seconds. It was in the 20-minute range. Again, completely delineating a different group of patients. You've been so patient.
David.
Very nice review, thank you. My question has to do with the clinical utility of these scoring systems. As a clinician, as a surgeon, I don't find them particularly useful. I think for clinical trials, it's important that we classify patients appropriately so that we can compare across groups. And if they're simple enough, I think it's nice to have a common language like Intermax has given us. But when you go to the bedside, your brain processes probably thousands or millions of variables, from the number of nurses that are in the room to the skin turgor to the big toe. I mean, you're taking in so much information that I think our brains intuitively do that. They tell us who's dying, who's getting better. And so I don't find that sitting down and calculating a score helps me as a clinician to manage the patient. So can you give me an argument why I should do that?
No, because I agree with you. So one, I didn't pick my topic. I appreciate being given the topic, but it was given to me. So I agree. I think that's the issue with these scores. I think that the two caveats I'll make is the SCI classification. I think there's one is we are shock physicians at a shock center. I think doing things like the SCI classification that makes it easier to send out for referring hospitals to say, all right, this is the marker of when I need to get this patient out of my hospital. That's one potential utility. But I think simpler is better. And I think you have two options, either really simple, like the SCI classifications, or at some point, our computer system will generate something and says, hey, this person is in this is like the news flash of the COVID-19, green to red, right? So, okay, your patient's in the red zone, transfer them somewhere else. And whether that's done with a simple score like SCI or a more complex score, that's up to our field to determine. But I think simpler is, I personally think simpler is better.
That's where I feel like we're going. We're trying to get to the point where the computers can make the decisions for us. And I'm not sure that's
just the warning flag. But that's what I like about the SCI is that what the SCI does is takes you, I always say to the interns, I'm like, you need to kind of just know two things as an intern. You need to learn sick versus not sick, and what you don't know, right? So know what you don't know, and then everything else we can help you. If you mess up those two things, we're in trouble, right? And so what the SCI kind of does is it goes sick versus not sick, and like super sick, mildly sick kind of thing. And so I think the SCI allows us to not necessarily use the computer. So
let me make a quick comment to interject on this, to answer David's point and to your point. I think we all agree as real bedside physicians, I call it the slope of illness. I trained sort of at Hopkins and Bellevue. From Bellevue, who's dying and who's not. Hopkins, we can give you all the fancy names. And I think that's what experience tells you. But the other point is that these scores, this system, this computer-based strategy, it's calming whether we like it or not. And we just got funded on an NIH study with the law school to take a look at, would you rather have a physician at the bedside make decisions versus a physician with Google making those decisions. The NIH is interested in that question because it's calming, because we've got administrators and the way the healthcare system works. And I'm not defending that at all. I'm still a bedside guy. But we have to adopt that. Otherwise, it's going to be foisted upon us, and we'll be behind the 8 ball.
Thank
And
you.
I'm
We have
kind of sad to hear that.
two more questions, because we have, in the sake of time, please.
So this is a fantastic discussion. All the things you're talking about are projects that I'm either trying to do or want to do or hope to do, looking at the effects of hemodynamics and sky stage, because we know that hemodynamics, there's a hemodynamic disease, and I have some echo data in a manuscript that maybe someone in this room might review, and hopefully you'll view it favorably, showing that hemodynamics still matter. It was sky stage. But I think the challenge is, we want to use a simple algorithm, right? But we're all very complicated, and so I don't think that the sky stages is quite as useful for me communicating with you or people in this room, because presumably we're experts or trying to be experts. It's for me to communicate with the outside hospital physician, and if we can communicate in a common language, and we can say, so let's agree this person's in cardiogenic shock and they're deteriorating. We're going to call that a D, and you're going to transfer them, versus this person was in cardiogenic shock and now you've stabilized them, and now they're a C and they're doing well, and maybe they don't need to be transferred. I think those are important things. And I think the issue of cardiac arrest we haven't talked about enough. I could talk about that all day. You guys have heard me talk about this before. Not all cardiac arrest patients are the same. There's a huge spectrum of illness, and we as cardiologists, and even me as someone who's interested in critical care and cardiac arrest, aren't very good at identifying the ones who are really sick but still will do well. And I think that's an area rich for future research, and it's something that we should always think about when we're thinking about our cardiogenic shock patients, because if half of them had a cardiac arrest, you can't just not care for them. You have to figure out how to care for them.
And I think one of the things about the sky classification is this concept of deterioration. I don't remember during what talk yesterday they talked about how they adjusted. If you put a balloon pump in, you have to reassess 30 minutes later. The concept of having to continually reassess, like shock patients from shock publications, et cetera, I think that's one of the key factors. And I think the nice part is it's simple. Like, if someone's doing worse, you should pay attention to that. And that seems super obvious, but it's not. Right? Because what I'd love to see is for us to somehow manage to shorten the time of doing worse. Right? We all get patients who, 36 hours ago started rising pressor requirements and end organ dysfunction, and then now we're seeing them. And it'd be great to recognize that early.
Thank you very much, Esther. That was a wonderful overview, and you have the last word.